Okay, I'm just going to start. Can everybody see my slides? Just shake your heads or type it in the chat. Okay, awesome. Thank you so much. All right, I'm Dr. Sharifi Hannauer. I'm a child neurologist. I am one of the clinical attendings at UCLA Medical Center in the Department of Child Neurology, and I'm also the medical director of Pediatric Minds. And we're located in Torrance, and we specialize in working with neurodevelopmental disorder in kids and provide early interventions. So today I'm going to focus our talk on autism and epilepsy. This is my usual annual talk. Did it last year too, and so made a few updates to it since then. Okay, all right. So we're going to focus on what the link between the two things are between autism and epilepsy, and that specifically is social cognition and understanding social cognition in each entity, both in autism and epilepsy. And then we're going to talk a little bit more about how other things connect autism and epilepsy. And we're going to spend a little time talking about the abnormal EEG discharges or epileptiform abnormalities that we see in epilepsy. And then we'll end it with future goals and research and questions. Okay, so cognition is very well known in the human species. We often talk about and hear about intellectual cognition, which is the ability to be aware of the world around us and to learn and use knowledge in an adaptive way from the world around us. But we often don't mention social cognition often, or that hasn't been like a very popular thing to talk about as a real entity. Well, social cognition is just as important as your intellectual cognition, and it really impacts your long-term ability to be independent and to function socially in the world. And it's defined as how you process, store, and apply information about the people around you and the situations around you. It involves understanding social signals and processing social cues, like understanding tone of voice, facial expressions, and it really helps us perspective take, put ourselves in other people's situation, which will overall help us engage in what we call pro-social behaviors, meaning keeping friendships, being able to cooperate, showing empathy. So it really is a very high level skill of cognition that impacts a variety of aspects in our life. So there's two main components that are often studied in social cognition. The first one is called theory of mind, and it really allows the social brain to explain and predict the behaviors of others so that we can understand what to expect of them and to help us understand what we should do in response to them. In other words, it's perspective taking. And so it helps us attribute emotional states of others and understand what they're thinking, their perspectives on things, and really how to be able to then predict what other people are going to do and how we're going to behave in response to what those other people do. It's a very intuitive, innate thing that we sometimes don't even think about because it tends to happen naturally. Second aspect of social cognition that's very important and usually studied in various studies is empathy. And empathy is the ability to not only understand someone else's emotional state, but to be able to match that emotional state within ourselves. So it's not just identifying the emotion like you would see in sympathy, but being able to do emotional perspective taking. And a really good example of it would be like a little girl comes home from school and says, "Mommy, my friend fell today and really hurt herself." Pain, empathy, sympathy. She was able to recognize that the kid was in pain, versus empathy is, "Mommy, my friend fell today and I felt so bad for her because I know she was embarrassed and then she cried and I know it hurt and she was embarrassed." So it's a deeper level of emotional understanding, not just identifying the emotions. So we know that the human species is one of the few species that the brain continues to develop after you're born. Unlike other animal species like cows or horses, when the calf is born, they just get up and run around, right? They're fully formed. But humans, the brain continues to grow and develop, especially in the first 10 years of life. And this happens through thickening of the cortex and an increase in the volume of the gray matter of the brain, where all the brain cells are. specifically in the prefrontal cortex, in the temporoparietal junction, and in the temporal lobes. And this schematic is really good to show how it progresses. So at birth, our cortex is kind of thin, and then through childhood, it gets thicker and thicker. Now, while this is happening, and the reason it's getting thick, it's because there's all these networks being developed. So there's an increase in connectivity in the brain between the long range locations or the long range networks. And then with the input that we get from our experiences, then there's fine tuning of those short range networks or primitive functional connections. And so then the short range networks become more specialized, whereas you have more long range networks. And then a process of myelination occurs on top of it all, where it sort of solidifies the functional networks that you want to develop in early brain development. And specifically, the biology of cognition and social cognition has been already established, and we know that there's certain parts of the brain that are actively involved in the development of social cognition, specifically in the temporoparietal area, the prefrontal cortex, and in general, the limbic system is strongly involved in social cognition and other forms of cognition. So, and this is a great schematic about how social cognition develops from birth. So our social cognitive system is there early on, and it is involved in this feedback loop where we have our sensory system putting in input, and then our motor system connecting with the sensory input to then help develop our awareness and social awareness. And really, from birth to 3 months of age, we start being able to have basic imitation skills, and this is all part of your social cognitive development. You're able to follow gaze and face detection, eye detection, and so on and so forth. So now, in terms of social cognition, and how does that relate to autism and epilepsy? Well, let's go over the definition of autism. So autism is a spectrum disorder. And the reason it's called a spectrum is because it's a neurodevelopmental disorder with lots of different underlying etiologies or reasons and causes, and lots of different comorbid things and lots of different severities are present. However, what's fundamental to autism is that it has social cognitive deficits. Specifically, they have poor theory of mind, and they have poor emotional perspective taking abilities or empathy. In addition to that, there's also the presence of restricted interest and repetitive behaviors and some sensory abnormalities. These deficits need to be present before the age of 3 to meet full criteria of autism. And the prevalence nowadays is about 1.4% in the general population. This is the DSM-5 updated criteria of how you meet diagnosis for autism that was put out in 2013 that I basically summarized in the slide before. So autism really is thought of as a primary social cognitive disorder and impairment. So we know from myriad of MRI and functional neuroimaging studies that there seems to be a paucity of long-range connections and an increase in short-range connections, sort of the opposite, the flip opposite of what we discussed in the previous slide about how in normal development, there's an increase in long-range connections and a decrease in short-range connections. And this is a really good schematic of the typical brain and the autism brain, how with activation, there's an increase, and with time, there's an increase in long-range connections, whereas in the autism brain, it seems to just stay more locally. And the thinking is, well, if that happens, then the connectivity is thrown off, right? And so when the connectivity of various systems in the brain is thrown off, then we have a problem in the interneuron communication and the organization of the brain as a whole. Another schematic is looking at functional MRIs, again, in the regular brain and in the autism brain. In the regular brain, when you're activated doing social tasks, there's an increase in long-range connections. And this one just shows there's a paucity of long-range connections. In functional cognitive learning, EEG data, again, in the typical brain, when there's activation or you're involved in social cognitive tasks, there's an increase in long-range connections, paucity of short-range connections. And again, in the ASD brain, there's an increase of what looks like just short-range connections. So we know that there definitely is something there. And we've seen it on these neurobiological studies. So epilepsy now is defined as two unprovoked seizures occurring more than 24 hours apart. And we know the frequency of epilepsy in the general population is about 1%. The International League of Epilepsy, League Against Epilepsy, put out their new criteria of how to diagnose epilepsies. And now we know that there's always a reason for epilepsy. There's 6 etiological categories, and those consist of genetic underlying reasons or structural underlying reasons, metabolic, immune, infectious, and there's a category of unknown. So this is our new way of really trying to look at seizures and epilepsy and classifying them. We know that epilepsy is one of the most common chronic neurological disorders in children, and we've known for a long time that it causes a lot of neuropsychological problems. But more and more research is showing that part of the neuropsychological disorder and problems that they experience also include social cognitive impairment. So epilepsy is also a disorder that's associated with social cognitive deficits and issues. So it's becoming much more of a relevant aspect in treating epilepsy. And we know that patients with epilepsy have deficits in theory of mind, as well as have deficits in emotional recognition compared to healthy controls. The other thing we've learned is that patients with lower IQ and epilepsy tend to have more severe social cognitive impairment, and more of them tend to meet criteria for autism. And this is seen in a lot of the epileptic encephalopathies, like in West syndrome or Dravet syndrome. So and I'm just going to go over a few studies that kind of highlight the point of what I'm trying to say in terms of how much epilepsy impacts social cognition. So there was a large meta-analysis looking at 1,300 patients, and they found that, and these were specifically in patients with temporal lobe epilepsies, that the biggest aspect of social cognition that was affected was the recognition of fear, followed by disgust, sadness, and anger, and then surprise and happiness. And then there was a study looking at children who had normal IQs with epilepsy, and they also found that there was impaired social cognition in those kids with normal IQ and focal epilepsies and even with generalized epilepsies compared to healthy controls. And there were similar findings in patients who have idiopathic generalized epilepsies. And we know those patients often have preserved IQ, and that's things like childhood absence epilepsy. So social cognition tends to be impacted in epilepsy regardless of IQ, but for sure in kids who have more significantly impacted or lower IQs, then social cognition is definitely more affected. And then there's studies that even look at the presence of social skills in some controlled studies before seizures start, and there is evidence of some sort of social cognitive deficits even before the first seizure ever occurs. And these are probably in a lot of the genetic epilepsies that they've looked at to see if there's any evidence of what sort of neurocognitive deficit seizures cause. And there are studies looking at social cognitive deficits in epileptics that don't necessarily meet full-blown criteria for autism, but we know that it's there. Specifically, there is a disorder in the DSM-5 called the social pragmatic communication disorder, which is defined by difficulties in using verbal and nonverbal communication in naturalistic settings. And this impacts the development of social relationships and the comprehension of verbal conversation or discourse. And the definition states that it can't be otherwise explained by low IQ or autism. So a lot of people argue that perhaps a lot of the social cognitive impairments in epilepsy are like the early stages, or what would be sort of like a milder autism in these patients, and they don't necessarily go on to develop the full-blown criteria for autism. There's also, now looking at it the other way, what is the prevalence of autism in epileptics? And so there's a lot of studies looking at it that way, and it shows that about 6 to 9% of people with epilepsy also meet a full-blown criteria for autism. And that's definitely a lot higher than in the general population. Another really large study looking at 7,400 patients showed that the prevalence of autism was about 8%. And this was even in people who had normal IQ. So in general, there is a 7-fold increase in the odds of having autism in patients who have epilepsy, and that epilepsy is more strongly associated with autism when it's in adulthood, when it's seen in adulthood. And there's also just other studies not looking again at full-blown autism, but just some social deficits saying that they meet some characteristics of autism, and these are the patients that likely fall under the social pragmatic communication disorder. Again, a higher risk of autism in epilepsy and low IQ, the risk of autism in those who have epilepsy with intellectual disability, 16%, so higher than the regular number. And also there tends to be a higher risk of developing autism in epilepsy in patients who have early life seizures. So what about frequency of epilepsy and autism? Well, we know there's a strong association in that about 6 to 60% of patients with autism have developed epilepsy. And the reason it's such a wide range, and we tend to think of it as just 30%, is because over the last 20 years, the definition of autism has really changed and it's gotten a lot more broad, especially with the DSM-5 that came out. So it's a lot easier to diagnose patients with autism. We have a lot better understanding of what autism is. So that's part of the thinking of why there's such a wide range of the percentages of people who have epilepsy and autism. There tends to be a bimodal peak of when epilepsy happens in autism. One is in early childhood, and the second peak is around adolescence. We know that also epilepsy risk seems to increase in autistic kids as they grow into adulthood. So about 7 to 12% of kids with autism that are preschool aged have epilepsy, and this increases to 20 to 35% into early adulthood. So what are some of the risk factors of developing epilepsy and autism? Well, intellectual disability is a very well-known one. It increases your risk of developing epilepsy by 3 to 5 times. There's a large study showing that epilepsy was present in at least 20% of patients with autism and intellectual disability versus epilepsy being present in only 8% of patients with autism with no intellectual disability. And they also saw that just an increase of 1 standard deviation in IQ decreased the odds of epilepsy by 47% in the autism population. So that's very significant. The other risk factor of developing autism, epilepsy and autism is early onset seizures. So if kids who have early onset seizures are more likely to have both intellectual disability and autism. And that's because, as we saw earlier, early childhood is a critical time of development of your basic functions, specifically your social cognitive functions and linguistic abilities. And we know that if you have early onset seizures, this will often lead to more severe cognitive impairments, both socially and otherwise. And that's because then this abnormal activity during this critical period of development leads to a disruption of the connections within the neurons. And this will then impact other developmental skills. And this is clearly seen in our cases of epileptic encephalopathies. So when you disrupt the neuronal pathway, you cause functional deficits in the hippocampus when you have early life seizures. You cause synaptic reorganization and disruption of the organization, and eventually it leads to interneuron dysfunction and imbalance of the excitatory and inhibitory interneurons, which probably then increases your risk of having further seizures later on. This is a great little schematic from an article from 1993 that shows how rapidly the neuronal synapses develop in the first 2 years of life. So you can imagine when you have early life seizures, especially in the first year of life, how this can get impacted. So this is how many connections or synapses you have when you're newborn. This is at 1 month, by 6 months, and by 2 years. So again, if you have seizures early on, it can really throw off the synaptic organization and throw off all these connections. So what other things do autism and epilepsy have in common? Well, we know for sure that both are associated with intellectual disability. The presence of intellectual disability increases the risk of both. We know that early onset seizures increase the risk of autism. We know that they can have common genetics that we're going to discuss in a little bit. We know we've learned through studies that family history can increase the risk of both. And oftentimes they have a lot of similar comorbidities. So they got to be alike. There's got to be a connection. There's got to be a relation. So they both can have ADHD, anxiety, and learning disabilities. So real quick about the family history. So the presence of one really increases the risk of developing another. So if you have autism, your risk of epilepsy is higher. If you have epilepsy, your risk of autism is higher. And that's because, again, we've established they both impact social cognitive skills. There's a study that looked at the risk of epilepsy in multi-sibling families that have multiple kids with autism. And the rate of epilepsy in those families was 12.8%, versus in families that only had one kid with autism, it was 2.4%. And the study also looked at the risk of epilepsy in unaffected siblings of families that have multiple kids with autism. And that was 2.4%, still higher than the 1% that's associated. It's double the 1% that's associated with the general population. So these are some examples of early onset seizures, and a lot of the early onset seizures are associated with what we call epileptic encephalopathies that can be very devastating to your development. And these are the ones that are strongly associated with autism. One of them is West syndrome. It consists of spasms, hypsarrhythmia, developmental regression. The risk of autism in this population is anywhere from 30 to 70%. Dravet syndrome, the risk of autism is up to 60%, and it's higher, even higher than that if the seizure onset is in the first year of life. And the same with LGS, the risk of autism is a lot higher when the seizures occur in the first 2 years of life. In terms of genetics, we know that there's a myriad of genes associated with epilepsy, but we've also now identified over 100 genes and genomic disorders that are associated with autism, and a lot of them are the same gene. So this sort of argues for maybe there's a shared common biology between these entities, and somehow both of these entities impact various pathways in the brain in terms of how it controls development and how it impacts seizures. Specifically, the GABAergic system has been studied a lot, which is the inhibitory pathway of the brain, and it throws off the excitation and the inhibition that occurs in the brain that gets disrupted. So some examples of genetic syndromes that are associated both with autism and epilepsy are things like Phelan-McDermott syndrome, which is the SHANK3 gene mutation. 40% of these kids have epilepsy. Autism has been reported in 90% of these kids. TSC, or tuberous sclerosis complex, epilepsy reported in 80 to 90% of them, autism seen in at least 50% of them, higher if you have infantile spasms that occur in infancy. Angelman syndrome, epilepsy seen in 85 to 100% of these kiddos, and autism is at least 40%. So again, there seems to be in these cases some sort of a shared common biology between autism and epilepsy. So it doesn't seem like epilepsy is the primary cause of the autism, and autism is not an epileptic encephalopathy as we've established, although a lot of kids with epileptic encephalopathies do have autism. But perhaps seizures and these social cognitive impairments co-occur as a dual symptom of some shared underlying biology or pathway. And that seems to be the case in a lot of the genetic syndromes that we've talked about. So, and another way of looking at it, I got this really good schematic from an article from Tuchman. So they both have this underlying shared etiology that gives rise to the seizures and epilepsy. And then it also, the underlying problem impacts your cognition. And then within that framework, when you have seizures and epilepsy, it probably exacerbates or contributes or worsens the cognitive skills. And then we know that intellectual disability and poor cognition increases your risk of epilepsy. So this was a really good visual representation of how we think of the connection of autism and epilepsy. The comorbidities real quick that I want to touch upon, where they both have in common. There's many that they have in common. I was just going to talk about ADHD and anxiety, which again, the thinking is this is more evidence for there being a shared biology between autism and epilepsy. The risk of epilepsy in kids with ADHD is 30%. And the risk of autism in kids, of ADHD in kids with autism is 70%. The risk of anxiety disorders in the autism patients is about 40%, at least 40%, and this is an underestimation. And the risk of anxiety disorders in epilepsy patients is at least 22%, and it's even higher in younger patients. Okay. So now we're going to move on to another semi-controversial aspect of epilepsy and autism, and that is subclinical epileptiform abnormalities in autism. So a lot of patients with autism have a lot of discharges or abnormal EEG findings in their background activity, in their background EEG, as we see in background activity, and they've never had seizures or clinical seizures. So the prevalence of these subepileptiform abnormalities or in autism is seen that in about 60% of cases of kids with autism, they tend to have these abnormal discharges, even without clinical seizures. And these discharges can occur in the general population, but only about a 1 to 4% ratio, 1 to 4% range. There have been studies looking at the location of these discharges and what they mean. There's some studies looking at discharges saying that the most common site is discharges in the right temporal area, which is often implicated in social deficits. There's discharges in bitemporal areas and the left temporal specifically that's more implicated in language dysfunction, as well as discharges seen in frontal, occipital, and parasagittal areas, but the most common being in the right temporal or bitemporal areas. So these abnormal epileptiform discharges or underlying discharges seem to occur more in patients who have autism and low IQ. So autism and more severe IQ or intellectual disability correlates with a higher rate of EEG abnormalities compared to those that have milder or moderate intellectual disability. And only about 20% of higher functioning autistic patients seem to have these abnormalities. So it tends to happen more with more severe deficits in IQ. Again, this is another study that looked at behavioral issues in autism and how they correlate with these underlying EEG abnormalities. And they found that patients who have more severe self-stimming behaviors or motor stereotypies, the ratio of the frequency, the rate of abnormal EEG discharge is about 61% compared to only 31% in those that have milder stims. And the rate of abnormal EEG discharges in patients that are more aggressive, autistic patients more aggressive, 75% versus 0%. Another study then looked at in patients that have worse behaviors and lower IQ. They found that 60% of those tended to have discharges versus the higher functioning kids, only 20% had discharges. Please note that a lot of these abnormal discharges occur in sleep. So oftentimes when you get just an outpatient EEG, which is 30 minutes or 1 hour, you're not capturing all the various stages of sleep. So that's why part of the reason why there's so few studies is because it's very hard to get comprehensive overnight 24-hour EEGs on patients. But oftentimes you miss these findings if you don't have an overnight EEG because they happen in deep sleep. So what do these subclinical epileptiform abnormalities really mean? Can they have negative impacts on brain development? Well, we know from animal studies that persistent discharges in between seizures, especially in the prefrontal cortex, can impact brain development and eventually lead to deficits in social behaviors, even when the discharges are gone. And that these discharges are thought to, again, impact the intrinsic connectivity of the brain, just like early life seizures do. And then there was 2 big retrospective studies looking back at patients who had autism, and they found that the ones that had more impaired adaptive functioning tended to have more abnormal EEG findings when they were younger. And another study found that the ones that tend to have worse behaviors when they're older tended to have more abnormal EEG discharges when they were younger. But is it possible then, going back to our thinking of the shared biology, that these discharges are just a reflection of the underlying problem. So it's a symptom of brain dysfunction rather than the discharges causing the dysfunction. And this theory or idea supported more in the idea of the shared biology and common genetics in both. And in addition to it, there has to be some sort of genetic vulnerability to how the discharges impact you, because there are patients in the general population that have discharges and they don't have neurocognitive deficits. So the etiology, the underlying cause, may give rise to cognitive deficits, may give rise to the seizures and epilepsy, and may give rise to the epileptiform discharges. Now, whether there's an interplay between here, maybe, possibly, probably, but there's still not enough data out there to know for sure. Another thinking was, well, do the presence of these clinical epileptiform abnormalities then predict later epilepsy occurring, actual seizures occurring later on? A couple of studies more recently said that it doesn't seem likely. So this one study looked at 345 patients without seizures, and out of those 345, autism without seizures, 24% had these abnormal EEG findings, but only 9% later developed seizures. And these abnormal, in another study, these abnormal discharges were common in childhood and weren't really seen later in adulthood. And we do know that they do peak in childhood, and a lot of times they go away the older you get. But when you look at some of the epilepsy literature, it shows that a lot of patients with epilepsy and autism, when you look back in their EEG data, they did have more abnormal EEG discharges. So they found in this one study, they found that 73% of patients with epilepsy and autism did have abnormal discharges prior to even the onset of epilepsy. And maybe it's a temporally associated thing. It's a time sensitive thing where you start to have more abnormal discharges right before, or maybe you have normal discharges way sooner that you never catch or you miss when you look for it. So again, it's not fully supported. And maybe, again, these discharges are an indication of underlying brain dysfunction, an indication or a symptom of the underlying problem that's given rise to the autism. Nevertheless, despite paucity of studies, we know that EEG abnormalities can be correlated with more behavioral issues and cognitive issues, and it's something that we should monitor for and keep an eye out. So then this raises another topic of questions. What do you do when you see these discharges? Do you treat them? Do you not treat them? Well, there were several studies supportive of treating them. However, a lot of the medications they used to treat these patients were medications that we also use in psychiatry, like with Depakote, and we know Depakote is a mood stabilizer. So did the kiddos get better in these studies because it was a mood stabilizing effect of the seizure medicines, or did they get better because the EEG discharges went away? And it did correlate with the EEG discharges going away, but it could have just been a matter of timing, because we know with time these EEG discharges go away. And then there's studies that show, no, it's not worth using seizure meds. So really the decision to treat or not to treat hasn't been established as a standard way of practicing. And I think it depends on the child and really needs to be evaluated on a case-by-case basis. So things to consider before deciding to treat these abnormal discharges is the severity and the frequency of these discharges, how often they are, and what the child is like. So the level of cognitive and behavioral impairment of the child. And so if the child has very severe language deficits, maybe it's something to consider. And it can also depend on the location of the discharges, and you have to weigh the pluses and minuses of using an anti-epileptic medicine and if that's helpful or not. So just quickly wrapping it up. So autism and epilepsy are strongly related. We know that they both impact social cognition. Social cognitive deficits and autism are strongly associated with epilepsy. And identifying social cognitive delays or deficits, even if it's not autism, is critical in epilepsy care, because you can provide early interventions, you can do things to really mitigate it and help things get better. We know that the co-occurrence of both may reflect a common underlying biology or shared genetic. We've learned that seizures in the first year of life really increase your risk of developing autism later on. We know that the presence of intellectual disability increases the risk of both autism and epilepsy, and the risk of autism seems to be highest in those with epileptic encephalopathies, where there's both early life seizures and oftentimes associated intellectual disability. We know that autism and epilepsy share some comorbidities like ADHD and anxiety. Either way, we know that implementation of early interventions, behavioral strategies, therapies are important in the treatment of both. So what's important to do moving forward? Well, it's really important to keep an eye on your social skills when your child has seizures or epilepsy, and really monitor social cognitive deficits and do testing for autism so that you can start implementing early interventions. It's important to do genetic testing. Now we have microarray, copy number variant, which shows our copy number variants, which is really simple and easy. Insurance will usually cover it nowadays, and it can give us more information in terms of your propensity for developing other medical issues like epilepsy. If you're going to get an EEG, and if it's indicated, it's really important that you do the gold standard of getting an overnight EEG to capture the stages of sleep to see if there's any discharges or not. And it's also important to monitor and treat the comorbidities like anxiety and ADHD, because we know these comorbidities will definitely get in the way of your other developmental skills. If you're very anxious and you can't participate in speech therapy or your early interventions, you're not going to benefit. So good management of epilepsy and social cognitive deficits or autism symptoms can greatly improve quality of life. We definitely need a lot more research in the future to better understand what these EEG abnormalities mean and if we should treat them or not. And we definitely need more studies just looking at potential biomarkers in order to be able to find simplistic ways for us to be able to pick up on if this child is prone to autism or not. And with that, I conclude, and I'm open to questions. If there is no questions, I'm going to wrap it up. Thank you so much, you guys, for your time. Oh, hold on. There's a question. Hold on. There is a question. Let's see. Do you have any advice for parents who are struggling to get their epileptic child even evaluate for autism right now? Oh my goodness, this is such a good question. So since COVID has happened, there's been such a backlog and a limited availability of resources to get kids tested. But your first place that you can always go to is the regional center. They're supposed to be able to do autism testing starting at 18 months of age. I know that Harbor Regional Center, the neuropsychologist, has said they won't do it until the age of 3, which is ridiculous because we know the sooner you start early interventions, the better. But you can always go to your local regional center. Your other option is just the various clinics. So you can go to the UCLA Autism Evaluation Clinic. You can probably go to the Boone-Fetter Clinic at CHLA, the Stramsky Center. You can also try to find a private psychologist that does autism testing. We also do it in Torrance at Pediatric Minds. And regional center can evaluate your child even though your child is older than 3. That's not correct. So they're supposed to be available to you for evaluations at any age. So I would call back and say, and specifically ask for an autism evaluation. It doesn't matter how old your child is. So don't let that stop you. And that was from Alicia. The next question is, do comorbidities like autism ADHD and epilepsy make the decision on medications more difficult? That is a very good question. It can. I know there are certain seizure medicines that sometimes can make behaviors a little bit worse. So you really have to take it on a case-by-case basis. In terms of treating ADHD, there actually is no contraindication in using stimulants and treating ADHD in patients with epilepsy. Treating ADHD in patients with autism and epilepsy really depends on the level of functioning, because a lot of the ADHD medicines that are like stimulants will exacerbate the tendency for autistic kids to self-focus. And so it sort of backfires on you. So yes, it can make a difference in terms of what you use. Yeah, these are all great questions. Any other questions? All right, guys, thank you for being here.